Dr. Sundarraj is now the consultant surgeon and laparoscopic surgeon in Coimbatore. Previously, he was the past chairman of the ASI of the Coimbatore City chapter and the ASI State chapter, the executive committee member of the Academic Council for 2 years, the organizing chairman for the TNSB Con in 2017. And now, presently, he is heading the Tamilnadu chapter of the Association of Surgeons of India as the chairman, an elite post for which he is richly deserved. And in Indian Medical Association, he is past president of the Coimbatore Coimbatore Association and also Central Council member of the IMA. And he is also, would you believe, the judiciary assignment is, he was the mediation judge in Coimbatore District Court, a direct appointment by the High Court. And professionally, he is a senior laparoscopic surgeon since 1993 in Coimbatore, and he did his DLS from the European Institute of Laparoscopic Surgery in Strasbourg, France, and also practicing ultrasonography. And he is the first one to introduce laparoscopic ultrasound in the arena of laparoscopy in India. And he is a faculty in laparoscopic surgery with the IAGES, the International Gastrosurgical Club, the International Society of Gynecological Endoscopy, and also in IASG and the Hepatopancreatobiliary Association Indian chapter. His assignments in public life are the member of Rotary Club, and he's married to Mrs. Saraswati, who served as a consumer court judge in Coimbatore, and she got us a lot of judgments in favor of IMA. And he's also the past vice district governor of the Lions International Club. They are blessed with 2 children. The first son, Dr. Suman, is an orthopedic surgeon, and he's an MCH and MRCS qualification practicing in Coimbatore along with his wife, Mathura Suman, who is the daughter-in-law, a medical gastroenterologist. Second son, Dr. Shravan and Ashwini, both a cardiovascular surgeon and a radiologist, are practicing in Bangalore. That is, in brief, in precise and concise, the qualifications of our Sundarraj, who is going to moderate the session, because this is a current session. And the elite Dr. J.K.A. Jameel, whom has in his profile a long list of qualifications, right from member of the Royal College of Surgeons to fellowship of the Royal College of Surgeons of England, of Edinburgh, of Glasgow, UK, USA, and senior consultant surgical gastroenterologist in the Apollo hospitals in Greams Road, Chennai, and also the Apollo Clinic, T. Nagar. And he is an honorary adjunct professor of not only Tamilnadu MGR Medical University, but also Apollo Hospitals Educational Research Foundation. He is editorial board member of the Journal of Minimal Access Surgery and also an examiner abroad and international surgical ambassador for the Royal College of Surgeons of Edinburgh, UK, and is examiner for Royal College of Physician Surgeons of Glasgow, UK, and is a distinguished clinical tutor of the Apollo Hospitals Educational and Research Foundation. He is a former National Executive Council member of the IAGES, the Indian Association of the Gastrointestinal Endosurgeons, and he qualified from Stanley Medical College, Chennai, and then he trained and worked in the UK for more than a decade, for 14 years. And he underwent the PG surgical training in Yorkshire, UK, and 2 years of basic surgical training, 2 years of oncology research, and 6 years of higher surgical training, and subspecializing in GI surgery and minimal access surgery. He underwent the robotic surgical training at the University College of London Hospitals and the robotic surgery in Grosseto, Tuscany, Italy. And he holds the fellowship from England, Edinburgh, Glasgow, UK, and the fellowship from the American College of Surgeons, and an MSc from the Surgical Research from the University of Hull, that's in East Yorkshire, UK. He was awarded the Research Grand Prize of almost £2,000 for Research Project University of Hull, and successfully obtained the certificate completion of UK training. As a consultant surgeon, UK, he has also taken on to him training number of surgeons on the Yorkshire basic and higher surgical programs, teaching faculty for FRCS International Examination Course, is a teaching faculty for the DNB, and that is diplomas in surgical gastroenterology and fellowship of the minimal access surgery candidates at Apollo Hospital, Chennai, has participated and presented in over 100 surgical conferences in Europe, USA, and Asia, has to use credit a number of peer-reviewed articles published in international journals. And that again, in very short, I had to make it concise and precise to bring about the entire panorama of his biodata and CV in a very, very short skull to talk about laparoscopy, which has panoramically expanded in the past more than 3.5 decades, to robotic surgery, which is again in the past 1.5 decades has grown from the Da Vinci days now to our own mantra in Gurgaon, in Delhi, wherein our own Dr. Mail Sami Annadurai is also the director of this Gurugram, who has drastically brought down the cost of the robotic surgery, and this has made way. And to answer Dr. Sridhar, artificial intelligence is not the intelligence, but it is how it can recall whatever, because we in the brain have 2.5 petabytes and we do not have to recall because it is all embedded there. This is a super brain, and the artificial intelligence can definitely help us when we are fatigued, and it will not definitely take over robotics. And to throw more light on this, Jameel, podium all yours, and invite Dr. Sundarraj to go ahead and moderate. And I see Prasanna Kumar Reddy, sir, who is there in Apollo Hospitals. Thank you very much, sir. And for everyone who are here, and Jayalal, President of the Commonwealth Medical Association, thanks, Jayalal, for all your presence here. This adds stature to the presentation.
Lab surgeon, Dr. Jayalal.
And Jayalal, our president, very, very proud to say that he will be representing us in the Buckingham Palace in the presence of the King of England very soon.
March 8th, March 10th. Okay. Come on, Jayalal.
Thank you.
Please.
Thank you very much, sir. Thank you for this wonderful opportunity. I'm very happy that as academic committee chairman, you are right from the beginning, you are doing a great job in the academic field, whether it is in API or as an examiner for the Royal College, and your contribution in the academic field is excellent. And it is always my pleasure and privilege to have Dr. Samir Basha, my mentor in the laparoscopy surgery, and one of the person who is now internationally recognized the luminary in the laparoscopy surgery. I'm so happy that you have selected Dr. Jameel, the gem of one of the surgeons, laparoscopy surgeon or a clinician we have, a man with a lot of enthusiasm, compassion, simplicity, and the clarity in thoughts, the way they're very passionate in teaching. And he's also an examiner of the Royal College and a great person. I'm extremely happy today IMA is recognizing him and inviting him to give this wonderful lecture. I mean, it will be a great contribution of Dr. Jameel to Indian Medical Association. He contributes a lot to ASI, IAGS, but I'm so happy to see him in the IMA podium trying to give this knowledge dissemination. I'm sure this will be of a great benefit. So my hearty congratulations to the speaker, the organizer, especially the academic committee team chairman and the entire team. So looking forward to hear from Dr. Jameel and his lecture. Thank you, sir.
Thank you. Dr. Gunasekaran sends his best wishes, our immediate past national vice president. So I think we'll proceed.
Building construction.
Come on, please. Dr. Sundarraj, please moderate the session and start the topic, sir, please. Dr.V.Aruljothi?
Sir, yes, sir. Sundarraj, sir, disconnect item.
Sorry. Yeah, got it? Got it.
Please.
Yeah.
Good evening,
Sundarraj.
my dear brothers and sisters in Indian Medical Association and Association of Surgeons of India who have come over this session in this nice, hot evening once things are getting cold. The topic chosen by the Academic Council Chairman, Dr. Ashraf, is something great. He has concentrated on each and every developments, updates in each and every field for the benefit of the doctors of Indian Medical Association. So really, I congratulate him for this wonderful choice which he has made as a convener of this academic committee. Respected, most beloved TNSB President, Dr. Sengattuvan sir, Dr. Karthik Prabhu is yet to join us, and my beloved friend, Dr. Zamir Basha, who is the chairman-elect of the ASI, Tamilnadu, and past presidents of Indian Medical Association, Dr. Abul Hassan, my beloved brother, Dr. Jayalal, and my teacher in laparoscopic surgery and guru, Dr. P.K. Reddy sir, and the wonderful speaker of this day, Dr. Jameel sir. It's nice to be with you all in this nice evening. Science has witnessed a lot of changes. About 100 years back, the first started was an agricultural revolution. Then came the industrial revolution. Then came the technological revolution. Now we are in the digital revolution. The digital revolution has penetrated into each and every field of our life. It has not spared even our medicine. In medicine, you take any branch, there is penetration by the digital revolution. Once its penetration in our gastrointestinal surgery is going to be discussed in this evening. The wonderful topic just chosen, Dr. Jameel, with a wide knowledge in the field of surgery, laparoscopy, robotics, and I think AI, artificial intelligence, also is before us for this day. And we are hoping to expect a great message from Dr. Jameel. Jameel. Thank you very much for the wonderful opportunity for having chosen me as a moderator of this evening. And over to Dr. Aruljothi, the co-convener of this program. Aruljothi, please.
Yes, sir. Jameel, sir, we can start the program, sir. Yes, please.
There are already 250 participants. 260.
Dr. Arul, shall I share my screen now?
Yes, sir, you can share now, sir. Your co-host, you can do it.
Yeah.
I think mute everyone, Jyoti, so we don't
Yes,
have
sir.
any.
Yes, sir.
Please tell me, Dr. Arul, if you're able to see my screen.
Yes, sir.
Yeah,
Yes,
yeah,
sir.
yeah.
Is
Clear.
my-
Yes.
am I audible?
Yeah.
Yes, sir. Konjam close on the screen, sir.
All right. Good afternoon, ladies and gentlemen. First of all, I would like to extend my heartfelt thanks and gratitude to the Indian Medical Association, Tamilnadu State Branch, for inviting me to give this lecture at this prestigious online academic event. It's really a privilege and an honor for me to be giving this talk on this occasion. And I'm even more excited to give this talk in front of many stalwarts, both in IMA as well as in Association of Surgeons of India. I hope over the next 30 or 40 minutes, whatever we're going to be hearing is going to be beneficial for everyone. And I've tried to make this talk as general as I can because I know this is a mixed audience. It's not a pure surgical talk. So forgive me if I'm going too basic, particularly the surgeons in the audience. I may have to go too basic on certain aspects and then touch upon certain deeper details which may be of relevance to experienced surgeons. So the topic that has been given to me is gastrointestinal surgery in the era of laparoscopy and robotics. Now, why are we talking about this topic? Well, this is precisely the era in which we are living. The era in which we are currently living in. We have thousands, tens of thousands of surgeons who have got decades of experience of laparoscopy. Advanced laparoscopy has peaked. Almost every operation inside the abdominal cavity has been attempted successfully laparoscopically. And at the same time, robotics is coming in big time. Robotic surgery is entering every field, be it GI surgery, gynecological surgery, neurosurgery, orthopedic surgery, cardiothoracic surgery. And therefore, we are living in a very interesting era where there is a nice overlap of laparoscopic surgery and robotic surgery. And therefore, there are lots of things that need to be said and discussed. So let's start off by going to some basics. What is laparoscopy? Well, it's basically performing an operation in the abdomen by making just holes instead of making a cut. Before we dwell into the nitty-gritty of laparoscopy and robotics, I want to take you through a bit of a history here. Most of you may not be aware that the first laparoscopic appendicectomy, which is by far the most common general surgical operation, was actually done by a gynecologist, not by a surgeon. And that was in 1983. That's simply because gynecologists were far ahead of general surgeons in the 60s and the 70s when it came to minimally invasive surgery. It was only in 1985, a general surgeon by the name Eric Newhay came up with this concept of removing the gallbladder laparoscopically. And he used an instrument which he called as galloscope, which was quite different to the kind of laparoscopes that we see today. The current version of laparoscopic cholecystectomy was introduced in the late 80s by Philip Moret and Francois Dubois. A few years later, laparoscopic fundoplication came into the arena. And in 1991, round about the same time fundoplication was introduced across the Atlantic, Jacobs and Fowler did the first laparoscopic colon resection. Inguinal hernias, I'm sure the surgeons in the audience are well familiar. This TAP and TEP. TAP was introduced in 92, TEP in 93. The mid-90s saw a lot of improvement in laparoscopic surgery. There was laparoscopic gastric bypass in 94. The Japanese went big time with D2 resections laparoscopically. And the real game changer was when Michel Gagné published his first laparoscopic Whipple's procedure in 1994. And really, there's been no looking back. There's been an exponential rise in the numbers of laparoscopic surgery worldwide. And today, I mean, as of now, 2025, all of us as surgeons, as a surgical community, we can confidently say that every surgery inside the abdomen has been successfully performed laparoscopically. So why has it become so popular? Because it causes less pain, reduced respiratory complications, reduced wound-related complications. Patients leave hospital early, they get back to work early, the mobility is good, and last but not the least, the scar is a much better scar. In the textbooks that all of us were reading in the 1990s, there were certain contraindications for laparoscopic surgery. They called it as relative contraindications and absolute contraindications. If someone had multiple abdominal surgeries, or if someone was pregnant, or if the patient had cirrhosis, or if it was a perforated viscus, really the advice was don't do laparoscopic surgery. And if someone had ascites or an intracutaneous fistula, or if someone came with intestinal obstruction, laparoscopic surgery was a definite no. Now, fast forwarding it now, 2025, almost all of those relative contraindications have disappeared. We do laparoscopic surgery for pregnant people, we do it for obesity, we do it in cases of perforation, we do it when people have peritonitis, we do it in intestinal obstructions. And so really, what is left is just those three things in red. People who are in uncontrolled shock, basically the ones who are not, who can't really tolerate a pneumoperitoneum and who are extremely sick, which is quite understandable. Thanks to all these lovely instruments, and there's been a steady and a healthy competition among the industry in this last, 3 decades. Without the support of the industry and the competition amongst them, and without these fancy instruments, we wouldn't have, as surgeons, we wouldn't have done what we have done so far. I mean, clearly, it's impossible to be doing major laparoscopic resections without the assistance of major, of energy devices like the one that you see there on your bottom left, and all these lovely retractors. Thanks to wonderful articulating instruments, and not to forget the staplers. I mean, I could not have thought about doing a low rectal resection and a colorectal anastomosis without this particular, purse string stapler, which you see on the bottom right. I mean, it's terribly difficult to go down to the pelvis and do a hands-on anastomosis. So really, staplers have made things really, really easy. Round about 2004, 2005, this concept of laparoendoscopic single-site surgery came up. Now, we call it a SILS, single incision laparoscopic surgery, but then when you read the papers, there are so many acronyms. There's SIMPLE, there's OPUS, there's SPL, there's SLAP, depending on which paper you read and which part of the world the paper came from. The idea is, all along, 15 years, 20 years, surgeons have been doing laparoscopic surgery with 3 holes, 4 holes, 5 holes. And then this concept of, why not do it with a single hole came up. It was quite attractive to start with, and many actually went into it. And again, the industry came with some lovely ports wherein you can introduce multiple instruments through a single umbilical incision. But really, I have to say, it hasn't really caught up the way, the tide, if you like. There's been issues with loss of triangulation, clashing of instruments, and a lot of studies which compared with standard laparoscopy didn't show much of difference. And of course, there was a cosmetical advantage to less. 3D laparoscopy also came up more or less the same time because, as I'm sure you're all aware, one of the limitations of laparoscopy, the traditional laparoscopy, is that it's 2D. So there's lots of depth in spatial perception. But when 3D came up, it was advertised as something that would cause less strain for the surgeon, less blood loss, and more, accurate tissue approximation, and so on and so forth. But then the question that really was going around, and this was the subject of discussion among surgeons in laparoscopic conferences, is that, look, we are now in 2004, 2005, 2006, and there were already thousands of surgeons, tens of thousands of surgeons worldwide who have accrued 15 years of experience by that time, 20 years of experience by the time. And I know a few of them are actually here listening to me talking today. So the big question was, okay, it's great for training purposes. It's great for a junior doctor to understand and to get that advantage of 3D. But really, does it cause any improvement, or does it really give a superior outcome for the patient, for a surgeon who's already an advanced laparoscopic surgeon? So really, that also didn't really pick up as much as what was anticipated. And then all these adjuncts came up: laparoscopic ultrasound. I understand. I mean, I just heard during the introduction that Dr. Sundarraj sir apparently has got a lot of experience in laparoscopic ultrasound, which was very, very interesting to hear, because there are not many surgeons in India who can perform a laparoscopic ultrasound. It's a wonderful adjunct to have. It's a beautiful replacement for intraoperative cholangiogram. There's no radiation exposure. Numerous studies have shown that it is equivocal or marginally superior to an intraoperative cholangiogram. It's not just for biliary pathologies. It's also great for assessing the depth of lesions, identifying whether the lesion is solid or cystic when it comes to pancreatic lesions, vascular invasions, and so on and so forth. Near-infrared fluorescence is something that has come into laparoscopic surgery, and it still remains. I mean, there's still a role for it. We call it as, we commonly as surgeons, we call it as ICG. But really, if you want to use the generic name for it, it's near infrared fluorescence, which is NIRF, and that's how the literature, that's how you will see the literature calling it. Why are we calling it ICG? Because it's the abbreviation for the dye that we introduce. It's called indocyanine green. It's introduced by the anesthetist at the time of surgery, and then you just change your laparoscopic light from visible light to near infrared light, and you're able to see the beautiful delineation. Now, which is the organ you want to get delineated? It depends on the timing of injection of the ICG. If you want your cystic artery to come up nicely, it needs to be within 60 seconds. If you want your bile duct to be delineated, it needs to be about 10 or 15 minutes. And there is a belief that using ICG will decrease the potential for bile duct injury, which is fine. It has been proven, tested, tried. But the way I see it is, if a junior surgeon is practicing or is getting trained to do laparoscopic cholecystectomy, he should be able to perform a laparoscopic cholecystectomy safely, even without an ICG. ICG is an adjunct. There should not be a situation where he will be able to do it only if there is an ICG, because that's a dangerous situation to be in. You should know your basics. You should be able to dissect well, and you should always understand that these adjuncts are adjuncts and not replacement for safe surgical principles. They're also useful in bowel resections to look at the vascular supply at the stapler line, and very important when it comes to esophageal conduit. You've done the conduit. You want the conduit to reach all the way up to the root of the neck, the upper thorax, or sometimes even up to the neck, and you want to make sure that the right gastroepiploic artery is nice and strong all the way up. And ICG is extremely useful before you go ahead with the anastomosis. And same is the case with colorectal dissections. So with all this happening in the laparoscopic world, robotic surgery comes in. So what is robotic surgery? Well, it is a minimally invasive surgical technique where specialized robotic systems are employed to assist surgeons in performing procedures with unparalleled precision and control. Now, I'm not going to say that this is a completely new surgery or a completely new concept. It is an evolution of minimally invasive surgery that basically combines medical science with robotics and engineering. So it's a fantastic evolution. And the common myth that goes around, thankfully not much among the doctors these days, because robotic surgery has been around for more than a decade now, in India at least. And so it has, the knowledge has percolated quite well among the medical community. But you will see the public coming and asking you questions. Sometimes even the educated and the elite section of the public asking you a question. Doctor, I've heard about you. I've read your profile. I know your qualifications. I would rather like you to do the operation than the robot. And it's our duty to tell them, well, it is the surgeon who does the surgery. The robot is only a tool. So basically, it's our collective duty to educate the general public that robotic surgery is a tool in the surgeon's hands. And really, the tagline has to be, you get good outcome with the surgeon's skills and the robot's precision. So again, I'm trying to keep this talk as basic as I can. So what is robotic surgery? We've just heard about it. And I want you to have an understanding of how this robotic surgery is done. So basically, there are three components, and the illustration that I have there in front of you is a Da Vinci Xi robot, which is manufactured by a company called Intuitive. There are three components. There's a surgeon console, there's a patient cart, and there's a vision cart. Now the patient is on the trolley. I want you to focus on the middle picture now. The patient is on the trolley, and the patient cart, well, the ports are inserted exactly like the way you will introduce laparoscopic ports. And after the ports are inserted, the robotic arms are attached to the ports, and that's what we call as docking. Once the robotic arms are attached and the targeting is done and the robot is set, I move away from the patient cart. It's my staff nurse and my assistants who are going to be with the patient, and I move away 10 or 20 feet to the surgeon console, and I'm going to be there for the rest of the operation. Of course, I might want to come back in for retrieval of specimen and closure at the end of the operation, but the operation is done by me at the surgeon console. So what is a surgeon console? It is this instrument that you see on the left-hand side of the screen. Basically, there are master controllers which are operated with my fingers, and in these foot pedals. Time doesn't permit me to go into the integrity of that surgeon console, but sufficient is it for you to understand that all the operating is done from the surgeon console, and whatever movements I make with my fingers at the surgeon console is translated to movements of the instruments at the patient cart. And the whole process is watched by the entire team in the operating room on the vision cart. The team watches everything that's happening on the vision cart, but I don't watch anything on the vision cart. For me, the vision is in the surgeon console in those two little eyepieces that you see on that equipment. So that's basically how this is done. So how did this robotic surgery evolve? It's very interesting when you read about the history of robotic surgery. Mankind has been using robotic surgery for over 100 years. You'd be surprised. Robots have been used in agriculture. Robots have been used in automation industry. Robots were used in space industry. I mean, NASA has got an excellent track record of the usage of robotics. So when did healthcare professionals jump in? Well, they have been on the case for a while. If you look at the paper, to read the papers, it's been ever since 1960s, 1970s. But then the first documented robotic surgical procedure was actually a neurosurgical procedure. It was done in California, and it was done using a robot called a Puma 560 in 1985. Across the Atlantic, in Imperial College London, the urologists got hold of that concept and they thought, to themselves, TURP, well, it's an operation that requires precise movements of shaving of the inner lining of the prostate. And the movements have to be precise and the movements are repetitive. So a robot might be a very good equipment to do this. And so they brought the concept of the Puma 560 and they adapted it to their urological procedure. And they devised a robot called Probot in 1988. Orthopedic surgeons also came into the arena, and prosthesis measurements were done using a robot called Robotic. The concept of bringing robotics into laparoscopic surgery was actually started in 1994. There was a company called Computer Motion. Computer Motion is actually a name of a company. And that company first manufactured a camera arm in 1994. And it was initially just the camera arm, which was the robotic part of the operation. All other instruments were the standard instruments. So the camera arm was a robotically controlled arm. And it worked. It worked very well. People were happy with it. Whoever was using it, of course, it was in a very, in selected centers, and they were quite happy. But then the thought arose among the surgeons and the engineers, if I can do it for the camera arm, why not do it for the operating arms? And so they came up with the operating arms, and they had different names for it. The operating arms were called Zeus, and there was a different name for camera arm, and that was really an innovation in minimal access surgery. 1998 is a kind of a very important era or year in robotics, because that's when Intuitive was born. They came with their first surgical robot, Da Vinci. And this Da Vinci by Intuitive got FDA approval in 2000. So we are looking at 25 years ago. And in the year 2003, this pioneer company called Computer Motion, which came up with this camera arm and operating arms and all of that, merged with Intuitive. So that was 2003. And I have to say, from then onwards, there's never been any looking back. And today, worldwide, Da Vinci robots are the most popular and the most widely used robots. And they have come up with numerous improvements in the last 20-25 years. The first one was called Da Vinci. The next version was called Da Vinci S. And the third one was called Da Vinci SI in 2009. And the one that is currently in use is Da Vinci XI, which came up in 2013. And interestingly, they also have a single port version, a single port robotic, single port Da Vinci robot. That's called Da Vinci SP, which came up in 2018. There's another one called Da Vinci version 5, which was released in late 2024 in the US. I have not had a chance to see it as yet in India, but I'm told it has some fantastic newer facilities. It's not just the Da Vinci. There have been other players in the market as well. There is this surgical robot called Hugo, which is manufactured by Medtronic. And I have to say, I'm actually privileged to be working in an institution which has both Hugo Medtronic surgical robot and Da Vinci XI surgical robot. Thanks to our chairman, Dr. Pratap Reddy, we've got two robots from two different companies, very well-known companies in the same institution under the same roof. And all I can say is we are privileged to be able to work on these lovely machines. There's also the British version. CMR stands for Cambridge Medical, and they call their robo as FRCS. And this is the Indian version, which Dr. Zamir Pasha was alluding to during his introductory speech. It's called SSI Mantra. But then, as I said before, it's the Da Vinci XI by Intuitive, which have really been the market leaders. And that's the robo which I use for most of my robotic surgeries. And the operation that I'm going to be playing in a little while, the subtotal gastrectomy, is an operation which was done on Da Vinci XI by Intuitive. This is the newer version, which I talked about, launched in America in 2024, just a few months ago. I'm told it's ergonomically much better, and also the haptic feedback issues have been resolved. But as I said, I can't comment much about it because I've not seen it, I've not had a feel of it. So what are the advantages? There's definitely better visualization. There's a 3D image with greater depth perception. And the laparoscopic surgeons in the audience, I'm sure, will agree with me that when you have a bad cameraman, when you have a cameraman who doesn't know what he is really is supposed to be showing, it can cause a lot of strain to the surgeon. And so sometimes you wish, you had an opportunity to deal with the camera yourself, but then you only have two hands. Now, how are you going to deal with it? That problem has been completely taken away in robotic surgery. As a surgeon, you control the camera. And the one that is by far the most popular and most interesting advantage of this robotic surgery is this dexterity and increased range of movement, multiple degrees of freedom, allowing a surgeon to operate in difficult areas and access difficult areas. Tremors, well, when one gets old, when a surgeon gets old, and when tremors become a problem, if he's not able to execute his task properly, certainly, laparoscopy or open surgery will be difficult. However, with robot, there's no problem, because whatever tremor you have is not transmitted to the patient, because your hands are on the master controllers, and the message going from the master controller to the instrument is a robotic message, and the robotic instrument has absolutely no tremor whatsoever. So that's going to do the job for you. Lastly, I mean, certainly, this is the last point is something that we really can't say as an advantage for the patient, but this is an advantage for the surgeon. You sit and operate. You don't stand and operate. So if you can sit and operate, obviously you can do long surgeries without much of physical strain, and you can also do multiple surgeries in a day. Disadvantages, definitely expensive. There's no doubt about it. And it's not just the cost of installation, but also the cost of maintenance on a yearly basis. But then, like everything else, it is envisaged that this cost will come down over the next few years with increasing market competition. Insurance approvals have been an issue with robotic surgery, at least in India. But I mean, that's largely because the clause of robotic surgery is not being included in most people's policies. But I feel with increasing awareness and with some changes in regulations, that's going to be changed as well over the next few years. Yes, robotic surgery, there's a talk about docking time and overall the surgery time taking longer. But I believe it does not make a huge difference when it comes to advanced procedures, because you have a better precision, you have good tissue planes, you have less blood loss, and therefore you keep operating smoothly without having to deal with any issues that arise from operating in a wrong plane or developing a bleed and all that. And therefore, if it is a long operation, whatever time you spend in the initial docking and the later undocking, you are likely to compensate for it by your smooth surgery. But that's only for longer surgeries. I mean, when it comes to short surgeries, I mean, if it was a simple gallbladder and if you're having to do it, if you're able to do it in 20 minutes or 30 minutes, really, having a robot doesn't make things any better. Lack of haptic feedback, as I mentioned to you, this is definitely a problem. With laparoscopic surgery, you can feel in addition to see, but with robotic surgery, you're only able to see, albeit you're able to see it very well, but you're only able to see, you're not able to feel. I'm told the version 5 has got some features to address that issue. We'll have to wait and see how that works. So let's look at some evidence. These are some important slides, really. There is no level 1 evidence, when I say level 1, I'm talking about meta-analysis, I'm talking about, systematic reviews and so on. There is no level 1 evidence to prove there is any significant difference in common laparoscopic procedures between, like cholecystectomy and inguinal hernia, between a robotic approach and a laparoscopic. And I have
Sorry, sir.
and I have shown you 2 papers there. Both of them are meta-analysis, and the top one is a meta-analysis comparing laparoscopic with robotic. It comes from Royal Sussex Hospital in Brighton in UK, and the next one is comparing robotic and laparoscopic inguinal hernia. So time doesn't permit me to go into the details of these papers, but then as of now, I mean, perhaps things will change later on when lots of other things come up into robotic surgery. But as of now, there is no level 1 evidence to show any difference between robotic surgery and laparoscopic surgery as far as these common operations are concerned. However, when it comes to some major surgeries, there is some advantage. When you have to operate in deeper locations, like deep in the pelvis or posterior to the pancreas, if you have to do a lymphadenectomy along the vessels, definitely the better precision and greater vision helps. So what is the comparison between robotic and laparoscopic gastrectomy say? Well, this meta-analysis published in 2020 says that there is a significant increased mean number of retrieved lymph nodes in robotic gastrectomy than laparoscopic gastrectomy, and therefore overall, it may be slightly better, but every other aspect were comparable. Now, whether that slight increased retrieval of lymph node translated into better overall survival, better disease-free survival is not within the purview of this paper that is shown, but that's something that this result is something that we need to take on board. When it comes to colorectal surgery, laparoscopic right hemicolectomy versus robotic right hemicolectomy, this is again a systematic review. There's definitely with robotic surgery, there's definitely more lymph nodal harvest. There's a lower rate of conversion to open surgery. There's a shorter time to passage of flatus. There's a shorter length of hospital stay, and therefore robotic right hemicolectomy, and of course there is an increasing chance of performance of anastomosis intracorporeally with robotic surgery, and therefore these have been reported as perceived advantages over laparoscopic surgery. What does it say about rectal surgery? Well, these 3 are landmark papers. If anyone wants to have a look at them later on, please feel free to take a snapshot and go and read about them. The ROLAR trial in the UK, it's from Leeds. I'm happy to say that it is from the institution where I got trained. David Jane from Leeds has been doing a lot of work on robotics for about 2 decades now. I remember very well from my days in Leeds. And this ROLAR trial was published in 2017. And David Jane, in this paper, his primary outcome was to look for any risk of, to look for in the conversion to open numbers. If you did it robotically, are you less likely to convert to open compared to if you did it laparoscopically? And the outcome of that, and there were other secondary outcomes as well, like sexual dysfunction, urinary disturbances, early return to work, early mobility, and so on and so forth. The result of that paper was that there was no difference between robotic and laparoscopic when it came to conversion to open and all the other secondary outcomes. But that was in the West. In the East, there was this Colrar trial from Korea, which also came up with a similar result. There was no reported difference between the two. They looked at the TME specimens. And when they looked at the TME specimens, they found that the TME specimen for laparoscopic and robotic were similar. And these are huge meta-analysis, huge randomized controlled trials. But I have to say the game changer was the one which you see right at the bottom. This is a Chinese multi-center randomized controlled trial, nearly 1,300 patients comparing robotic versus laparoscopic surgery for middle and low rectal cancer. And that paper clearly says that with robotic low rectal and with robotic anterior resection for low rectal and middle rectal cancers, there's a definite advantage in terms of increased disease-free survival, decreased recurrent rate, and increased overall survival. And therefore, this paper is a strong proponent and supporter of the advantage of robotic rectal surgery over laparoscopic rectal surgery. So the bottom line is surgeons should get trained, particularly the younger surgeons. There's no second thought about it. They should get trained in the usage of robotics because it's a futuristic step. It's here to stay. But this discussion about open surgery versus laparoscopic surgery, should not be this is my view. It should not be extrapolated to laparoscopic surgery versus robotic surgery. Open surgery was a completely different ball game altogether. And when laparoscopic surgery came up, there were so many things that were so different. But when it comes to lap versus robo, one needs to understand that they are both minimally invasive procedures. And so an academic discussion needs to be done with that in mind. Just because it's a robo, you can't say that it is going to be better. And I told you, I showed you, the papers, I showed you the literature, which clearly says a robotic cholecystectomy is no superior to a laparoscopic cholecystectomy. And similarly, a robotic inguinal hernia is no superior to a laparoscopic inguinal hernia. So as surgeons, on one hand, we need to be aware of the newer technology, and we need to get trained in the usage of advanced technology and think about what is in future for surgery. On the other hand, we shouldn't be simply following the market trend and not pay attention to the evidence that goes along with it. So from that point of view, I have to say that there is definitely a strong case for discussion along the lines of which surgeries would be better robotically and which surgeries really don't have any difference whether they're done robotically or laparoscopically. So what's in store for future? Many things, and this is why I say you've got to get on to robotic surgery, because whatever I am saying now is what the status is in 2025. But you never know what's going to be the case in 2035 or 45. And when these things that you see on your screen right now come up in the next 5 years or 10 years in robotic surgery, there's going to be a huge difference between robotic and laparoscopic. And at that time, if you're not into robotics, you're going to be missing out a lot. So what kind of things can come? Well, at the moment, the robotic arms are fairly rigid. I'm talking about not the ends of the robotic arms, but the way in which they get into the patient. It could become flexible. They could become snaky. Digital enhancements, augmented reality is likely to come. Basically, what it means is the robot will start assessing your performance, and it can give you real-time feedback. For example, if you've done a robotic sigmoid colectomy on one day, and if you've encountered a bleeding due to a dissection in a particular area, the robot takes memory of it, remembers that. And the next time you're doing a robotic sigmoid colectomy, as you're entering that area, the robot will remind you, will tell you, Mr. So-and-so, the last time you were in that particular area, you did this wrong, and therefore you had this bleeding. You better don't do it again. That's what, performance feedback and real-time suggestions. It could come, and it could get easily incorporated into the robotic systems. And then the robotic systems could be made to do automated tasks, like tasks which don't change. For example, if you bring two ends of the bowel together, and if it means that you just have to go over and over and over repeated movements, rather than me doing it, you can get the robot to do it, because you never know, the robot might be doing it better than me. So you got to think, these are all things that may happen in future. And somebody mentioned about artificial intelligence in the introduction. That's definitely going to come. There's no doubt about it. When artificial intelligence can come in other fields in our life, we are seeing artificial intelligence all around us. We're hearing about ChatGPT. We're talking about this Chinese thing, DeepSeek and other things. So I have no reason to think why it cannot come into surgery. It's come into medicine. Artificial intelligence has come into medical prescriptions. So why can't it come into surgery? It's definitely going to come, because there are lots of videos out there in the cloud by different surgeons, and all one has to do is to create an algorithm, put all these videos together, create an algorithm, and the day is not far when that algorithm will be incorporated into a robot and into a robotic system. And it is quite possible that the robotic system will be able to replicate the operation based on everything that it has learned. And remember, when the algorithm is created, when the robot gets that artificial intelligence, it's going to be, it has accumulated information from me, from you, from Mr. X and Mr. Y in America, and Mr. X and Mr. Y in Australia and China. It's a collective knowledge that it's going to get. And when that gets incorporated into the algorithm, we are ahead of, we are in for some exciting times. Now, when this is going to happen, it's anybody's guess. I really don't know. It could happen in 5 years. It could happen in 10 years. It could happen in 20 years. We'll have to wait and see. We just have to keep up with the pace of advancing technology. But the big question is, will the robot ever replace the surgeon? I feel it's a strong no. They're unlikely to replace, because they are designed to augment human abilities. But then the question, will a surgeon's role change in future? My answer is a definite yes. In 20 years' time, if you're a robotic surgeon, you probably won't be doing the same kind of things that you're doing now. Maybe some of the, this is my imagination, and I may be wrong. We'll have to wait and see. Perhaps some of the repetitive tasks will be delegated to the robot, and the non-repetitive tasks will be done by the surgeon. We'll have to wait and see. Interesting times ahead. Now, with that little background about minimally invasive surgery and robotic surgery, I want to spend the next 10 minutes or so just showing a video of a robotic gastrectomy. This is a 44-year-old gentleman who presented with intermittent epigastric burning sensation for about a year, no history of nausea or vomiting, no history of hematemesis, no history of weight loss. He was reasonably okay. He was no diabetic, hypertensive on medications, but otherwise okay. He was taking mixed diet. He was a non-smoker. He didn't drink. There was no family history of any cancers. General examination was entirely normal. His hemoglobin was 14. Kidney functions, liver functions were normal. And as one would do, we had to get an upper GI endoscopy for him, and he had this cauliflower-like growth in the gastric antrum. The scope wouldn't go beyond. Biopsy was taken. It was an adenocarcinoma. CT was done. T2N0 was the radiological staging, which is good, which is the kind of cancers that, as a surgeon, you want to see. So there's no need for any neoadjuvant therapy. They go upfront surgery. And these are the port positions. We used a Da Vinci XI robo. Robo is docked from the patient's right. Patient is in the reverse Trendelenburg position. 3 robotic arms along the line of the umbilicus, and then the Nathanson retracted to retract the left lobe of the liver. It's usually 5 or 6 ports altogether, and the stapler firing is usually done through the left iliac fossa. 12 mm port. That's what the robot looks like. As you can see, the patient is in the reverse Trendelenburg position, and we make a start. So, like in any upper GI surgery, the first bit is retraction of the left lobe of the liver using the Nathanson retractor. And then what one needs to do is targeting. If you noticed in the first few seconds of the video, there was a green color mark that came up, and that green color mark needs to be exactly over the place where the pathology is. And in this case, this is the gastric antrum. Once you get the targeting done, the robotic arms will align themselves in such a way that your ergonomics is at its best. So basically, the robot is helping you. You don't need to decide how to get of course, you need to put the ports, but then after you put the ports, the targeting will help you to get your arms aligned. And then with my left hand, I've got this grasper, which has got a bipolar attached to it. And in my right hand, I've got this wonderful instrument called vessel sealer. I say hands, but then really these are not my hands. My hands are in the master controllers in in the robotic surgeon console, which is about 15 feet away from the patient. But whatever I do with finger movements in the master controller in that surgeon console is being transmitted to these hands, these instrument hands, which are going into the patient. So the principle remains the same, whether you're doing open surgery or laparoscopy or robotic, the principle remains the same. What you're seeing there just now is the right gastroepicloic artery and the right gastroepicloic vein. So you clip them. So really, I mean, you need to know what you're doing. I mean, the robot is only a tool. So it's not a replacement for your knowledge of anatomy and your safe surgical principles. So dissecting the right gastroepicloic artery, dissecting the left gastric artery, right gastric artery, all of these are standard surgical principles, except that you're seeing the entire thing better with depth perception, and you have got some wonderful instruments in your hand. But the anatomy has to be in your brain. I mean, there's no replacement for that. So that's the first part of the duodenum, nicely pulled up. So once you've got the first part of the duodenum, mobilized from the head of the pancreas, you deal with those little vessels that run above the first part of the duodenum towards the liver, and you create that nice window. The window that you see there just now is a window behind the right gastric artery, and these are fairly robust vessels. So I wouldn't take a chance with just using a vessel sealer on these vessels. I would still clip them. And once you've got the right gastric artery nicely done, you have this wonderful window at the back. And this window is what is going to help you to fire your stapler. And by the way, this is exactly how you would do the operation if you were doing it laparoscopic. It's just the equipments, the instruments that are different. So you fire the stapler, and there is a stapler called Sureform stapler which comes with Da Vinci, and I use that as well. But on that occasion, for this patient, I used a standard endo-GIA stapler from the left iliac fossa port. The only difference being, if it was a robotics Sureform stapler, I would have either I should have had another arm to fire it, or I should have taken off this vessel sealer and introduced the stapler and done it myself. But because this was a 3-arm robotic surgery, I got my assistant to introduce the standard endo-GIA stapler from the left iliac fossa. Talking about artificial intelligence, there is a component of intelligence added to these staplers. The Sureform stapler is wonderful in the sense, even if you keep on pressing the buttons after you've engaged the stapler on the tissues, it will only staple when the tissue depth is appropriate. In other words, it will stop and start and stop and start depending on how it feels the tissues are. So you may be pressing hard, but it doesn't mean anything to the stapler. Your command is taken, but it is acted with a lot of intelligence that it has incorporated within itself. So really, with the Sureform stapler, you can't get things wrong when it comes to tissue thickness and so on. Of course, you need to know which structure you have to staple. So that is always there. But once you've identified the structure, the stapler will help you in getting the right amount of thickness to carry on with the stapling. So what you see there is the left gastric artery, which is called the high tide for any gastric cancer surgery resection. So all the lymph nodes along the infrapyloric, suprapyloric region and the lymph nodes along the left gastric artery have been harvested, and basically you've completed the D2 lymphadenectomy, and now you're ready for your resection. So this was a antral tumor quite close to the pylorus. There's absolutely no need for you to go and do a total gastrectomy. So it's a subtotal, and that's what you're seeing here. These are linear staplers. The one that you saw earlier for the duodenum is the same stapler, blue cartridge, and standard surgical principles. When you get a stapler and when you want to fire it for the second time, you go exactly in the jaws, because that's one of the areas, one of the places where leaks can happen. So concentrate on those things and use it till the end. Don't compromise. You've got to make sure that the staple line is well past the margin, I mean the upper end of the stomach. So the specimen is removed. You just leave it aside. You've got a nice bed there, complete resection, and now you are ready for your anastomosis. So this is a subtotal gastrectomy. So you've got options. You've got Roux-en-Y. You've got a loop. Of course, you've also got a loop and then a broad. So I chose to do a loop on that day. Just bring a loop of jejunum up and create the gastrotomy, create the enterotomy in the small bowel, and you do your firing. After firing, after creating the gastrojejunostomy, you got to close the enterotomy, and that's by the standard suturing. I felt that although I've been doing laparoscopic suturing for a number of years, I felt when I started suturing with the Da Vinci Xi robot, suturing became so easy and enjoyable. I mean, not that I don't enjoy the laparoscopic suturing, please don't get me wrong, I do. But this was one level up. And I mean, I don't know if you're able to appreciate that. The angle in which the needle goes and comes out of the tissues and the way in which I'm able to create the tension, it's just phenomenal. It just happens so effortlessly. I mean, I have fast forwarded in this video for want of time, but even in real time, you will be able to appreciate that it goes in exactly where you want it to go. There's no compromise whatsoever, and so the tissue approximation is brilliant, and you achieve it in a shorter period of time as well. So really, it's enjoyable. I mean, that's the word I would use. It's enjoyable to do robotic suturing in many areas where you will be struggling. I mean, you will eventually get it done as a laparoscopic surgeon. You will eventually complete your suturing, but it will be a bit of a struggle. But here it's not. So you've done the gastrojejunostomy and just place a drain. You take the specimen out through the umbilicus, always in a wound protector bag. That's what the specimen looked like. It's a complete specimen, and that's what the patient looked like after removal of the specimen. The total operating time was about 220 minutes, of which the robo was in use for 183 minutes. We had to change the instrument just once, and that is changing the vessel sealer to a needle driver. Patient did absolutely fine. He was out of bed on the first day. We removed the NG tube. We removed the catheter on day 1. He was drinking on day 1. The drain was removed on day 3. He was progressed on soft diet and discharged on day 5. And that's after a gastrectomy for a carcinoma of the stomach. Histopathology came back as quite good. All margins were negative. All lymph nodes were negative. He was actually lucky, this patient. He had an early cancer, caught on time and dealt with on time. Medical oncologist saw him and said there's nothing required, no chemotherapy required, and he was kept on clinical follow-up. So that's the robotic gastrectomy. So I think I would conclude with that. Once again, I thank all of you for your patient listening, and I thank the Indian Medical Association, Tamilnadu State Branch, for giving me this opportunity to talk about this wonderful topic. I shall conclude here, and I leave the floor open to discussion. And I will return the floor back to the chairman, Dr. Ashraf, and the secretary, Dr. Aruljothi. Thank you very much.
Thank you, sir. Thank you very much for superb presentation, sir. Sundar, sir.
Shall I stop sharing my screen, Dr. Arul?
Please, sir. Please, sir. Please. Sundar, sir, are you available, sir? Yes, sir. Unmute பண்ணிடுங்களே. நான் உங்களுக்கு ask to unmute கொடுத்திருக்கேன். நீங்க yes கொடுத்தீங்கன்னா போதும். Yes, done, sir.
Sir, shall I? Arul?
Yes. Yes, sir. Yes, sir. Fine.
I think we were literally mesmerized and floating in a astronomical level for the past 1 hour with a wonderful presentation of Dr. Jamal. He has taken us to a big ground, starting from the regular open surgery and finally ending in an astronomical level with the advantages of the robotic surgery. Still, I remember the days in which we have been studying, undergoing postgraduate studies, and subsequently starting practice. Surgeon as a leader of the team, facing all ordeals, starting from the bloody situation of the table, doing a surgery, and come out with a lot of head stress and strain. With a lot of technological advantage, but more so after the advent of laparoscopic surgery, we have made so many things very easy and simple. When supported by technology advances like ultrasound, imaging technologies, when we go inside the abdomen, really we are blessed with the definite diagnosis and we have to come finish the surgery and come out, making the life of the patient very, very comfortable with good recovery. In fact, now with the advantages of those hemostatic devices like ultrasound and technology, vessel sealer, all those things. Now, diathermy, all those things. Now this has made us life very, very comfortable. And Speaker Dr. Jamal has highlighted so much about the robotic surgery, which each and every one of us should learn. It's the right time to learn because it is the, all along we have been thinking, it is not just getting the robot inside and getting the job done and come out. No, it is a surgeon who is sitting in the console and does the job and the surgery is completed. But little small rather apprehension or feel, which I personally as a surgeon, we feel is, we don't have the sensation, perception of sense, touch sense in when they do the surgery. But with the incorporation of artificial intelligence, he said very easily, this also being solved. And the advantage of robotic also he very easily mentioned that the dexterity, the range of movement during surgery is extremely good, and with lot of precision we are doing surgery and get the job done very quickly. Tremors are almost abolished, and the tissue clearance, particularly the malignancy, is very good. The lymph node clearance is also excellent. And he also made it very, very clear on one more point, that with the incorporation of artificial intelligence in the system of robot, the robot itself will give you warning. Hey, you are going near the vessel. You are going to puncture it. No, don't. Come out. Come out. Stay away. Stay away. This is the thing, message which it will be giving to us. So it's a wonderful time we had in this thing. But in conclusion, I want to give a small remark in that as the technology is advancing, the people, our public, are very much with lot of high information. It is a high time we have to sit with the patient and elaborate and make it very clear to them what is possible, what is not possible, how much can be possible, all those things. So a good documentation, which I want to tell in this junction, is good documentation by discussion with the patient is very, very, very important, and we get the consent for the surgery. And message for the youngsters is, and rather practicing surgeons also is, stay updated with all latest developments so that you can become a master in no time. And IMA is a wonderful platform because IMA gives you professional indemnity insurance. Professional indemnity or insurance of the IMA is really very, very supportive of the surgeon rather while doing treatment of the patient. So with this, I thank you for the wonderful opportunity given. I congratulate the speaker, Dr. Jamal, for the lovely presentation which we had. Thank you very much, sir. Thank you very much. Bye.
Sir, 1 minute, sir. I have to congratulate you for
Yes, sir.
giving information about the patient explanation. It's very good, sir. Now the patient wants that type of discussion before surgery. I agree with you. Thank
Yes,
you,
sir. Yes,
Dr.
sir. Yes, sir.
Dr.
And
Jameel,
make
thank-
it documentation. Good documentation with what you had with the patient is very, very relevant. Documentation can be in any form. You give it in writing, video documentation, audio documentation, even mobile documentation is also allowed. This is a message which should reach each and every one.
Because
Thank you, sir.
patient
Dr.
Google,
Jameel,
sir.
Dr.
Google
Jameel,
market பயப்படுறாங்க, sir.
Dr. Sundarraj, I think we'll take up the questions. Thank
Yes,
you so
sir.
much, Dr. Jameel. Wonderful. And Dr. Sundarraj, Dr. Sundaramurthy, I think we'll take up the questions one by one.
Sure.
Yes, sir.
Aruljothi, please send the questions to him.
சார் சார் உங்களுக்கு வாட்ஸ்அப் பண்ணிருக்கேன் பாருங்களேன் சார் சுந்தர் சார்.
பார்த்தேன் ஒரே அப்படி பார்த்தேன்.
Take up the questions.
I think 2 questions have been asked. Am I correct?
Yes, sir. Yes.
Mesenteric adenitis and recurrence. I think the question goes to Dr. Jamal, sir. What about the mesenteric adenitis and recurrence in such situation? What is the role of laparoscopy and robotics, sir? Dr. Jamal,
Okay.
sir?
Yeah. So I'm not too sure what exactly they want me to talk about. Mesenteric adenitis is a very common condition. I'm sure everyone here in the audience will have come across patients with mesenteric adenitis. It's very common in children, and it's usually secondary to some kind of an upper respiratory tract infection. So a kid of the age of 10 or 12 or 8 comes to you with right iliac fossa pain. This is a typical presentation that a surgeon comes across. Comes with right iliac fossa pain, 2 days with a bit of lack of appetite, and it's immediately suspected to have appendicitis. But then you do an ultrasound, and the ultrasound says appendix is normal. There's a few nodes here and there. Sometimes, you end up even doing a laparoscopic appendicectomy, and the appendix comes back as entirely normal. And it turns out that with hindsight, this was just a mesenteric adenitis, which could have been managed with, conservatively with a bit of paracetamol and so on and so forth. So that's as far as mesenteric adenitis is concerned. Is there a role for robotic for mesenteric adenitis? Well, no, there isn't. Short answer is no. Mesenteric adenitis is a medical condition. It is not a surgical condition. But if you are talking about removing the appendix for a mesenteric adenitis without knowing that it's mesenteric adenitis, you're rather better off doing it laparoscopically.
Sir, shall we go to the next question, sir?
Please.
Jamal, sir?
Yeah,
Dr. Jameel. Dr. Jameel.
Yeah, my name is Jameel, sir. Yeah, thank you.
Sir, Jameel, sir, sorry.
That is okay. No, not a problem. I'm happy to take any number of questions. Please go ahead.
No. The next question is something rather funny or interesting. Outcome of laparoscopic and robotic surgeries in male and female patients. I don't know what is the in the mind of the questioner.
Okay. I don't have an answer to that question, and I don't. To the best of my knowledge, there have been no trials comparing male patients with female patients when it comes to robotic surgery. All the trials that I have shown, the gastrectomy trial, the right hemicolectomy trial, the ROLAR trial of rectal cancer, the COLRAR trial of rectal cancer, the real trial of rectal, they're all, hundreds of patients, mixed, male and female. That's not a categorization that has been adopted in any of the randomization protocols as far as I'm aware. And I don't see a reason why that should be done in the first place.